Ladies and gentlemen, dear speakers, dear guests, my name is Alexander Renkli. I'm the Deputy Head of Mission here at the Swiss Mission to the European Union, and I'm delighted to welcome you all here to today's Swiss breakfast on the impact of the COVID-19 crisis on patient safety. Patient safety is one of the most essential components of healthcare delivery. Without sufficient patient safety, the quality of healthcare cannot be guaranteed. This worldwide important issue will be specially addressed at the Global Ministerial Summit, which will be held next year on the 23rd and 24th of February in Montreux, Switzerland. The main focus of that fifth edition of this global summit will be on the implementation of concrete actions that are strengthening patient safety. Our guests here in the room, you have all received flyers on this event, and I'm sure that our guests following us online, if you drop us a line, we'll be happy to forward it to you in electronic form. The summit was originally foreseen to take place in 2020, and due to the emerging pandemic, it had to be postponed. And this brings me to the core topic of today's event. As we all know, the pandemic not only had an immediate impact on our everyday lives, but also put huge pressure on the healthcare delivery systems and in particularly also on frontline healthcare workers. Available evidence from the Organization of Economic Cooperation and Development, the OECD, and the World Health Organization demonstrates that the risk of harm and the risk of harm in healthcare has increased during the pandemic. It revealed a range of safety gaps across all core components of healthcare. Having said that, the crisis also created a significant potential to strengthen patient safety and can serve as a catalyst for change. Our distinguished experts today, Professor Didier Pittet and Mrs. Francesca Colombo, whom I warmly welcome, will address different questions at today's event. How did countries in Europe deal with the COVID-19 crisis in terms of risk and avoidable harm? What were the main challenges on the pandemic for patient safety? And given the lessons learned from this unprecedented pandemic, how can healthcare systems build resilience for the future? I am very much looking forward to what our experts have to say to these questions and as well to the discussion with the audience today. And with this, I give the floor to Ms. Isabelle Ory, who will moderate today's discussion. Thank you.
Thank you very much. So good morning to all of you in the room, and good morning to those of you who are following online. So I'm Isabelle Ory, your moderator for today's discussion. So first, let me introduce our two guests. Mrs. Francesca Colombo, you're the head of the health division at the OECD. Mrs. Colombo, you've many years of professional experience in the international activities on health and on health system. And OECD is currently, I think, preparing a report for the Montreux Summit on COVID and patient safety. Mr. Didier Pittet, Professor Pittet, is a Swiss infectiologist and epidemiologist. So we all know him very, very well in Switzerland because during the pandemic he was on TV a lot of days to tell us to wash our hands.
More than home.
Let's wash our hands and put some distance. He's, of course, the co-inventor of the water gel that we have here. And he's also the international expert that the French president chose to write a report on the handling of the COVID crisis in France. So thank you both for being with us in Brussels today. We will start the discussion in a few minutes, just the three of us first. Then at the end, you can ask your questions. If you're online, you can write them already in the chat. And if you're in the room, you can raise your hand at the end. But first, I'll leave the floor to our two guests that will help kick the discussion. So maybe we'll start with you, Mrs. Colombo, and so you will make us aware of how important the issue of patient safety is.
Sure, and you're right. I mean, it's a fundamental issue, and the OECD has been for many years looking at it, trying to develop data indicators, but also to support policy. Well, why is it important? Obviously, patient safety is a major public health issue, but also we are an economic organization. It has a significant cost, which the economic consequences of poor safety and safety lapses are really quite extraordinary. So if you look at some of the data and indicators that we collect, it's quite scary. I mean, it's like going into a healthcare setting. Sometimes it can be scary if you hear this data. Like 1 in 10 hospitalizations across the OECD countries has resulted in a patient safety issue of some sort. And 1 in 5 patient safety experience a medication-related harm during their hospital stay, for example. This is obviously across OECD countries. There are very varied and very large differences across countries. But also like something like 7% of patients report that they had medical mistakes at some point in their medical encounters. And so I think that the numbers are quite high, but economic costs are really quite extraordinary. Like 15% of hospital costs can be related to patient safety issues, and for the healthcare system as a whole, putting together what happened in hospital, but also in primary healthcare and in long-term care setting, we have estimated something in the order of 13% of total health expenditures that is related and linked to patient safety issues. So the consequences are tremendously, and the clear message that we have is that a lot of these can be prevented. I mean, a lot of patient safety issues are preventable with the right policies put into place. And we know what many of those policies are, whether they relate to institutions, whether they're related to measurement, whether they relate to healthcare professionals, clinical practice, and so forth. We know what they are. But very often we do have issues in the implementation of those policies as well. Again, on the issues of cost, it's also important because sometimes we have addressed these issues in context of low-income countries where resources are poor. And they always say, well, but it costs so much to implement patient safety issues. And actually, the cost of implementing patient safety issues are way below the cost of safety lapses. I'll stop there for the moment. Obviously, these issues have been perhaps brought to the fore and even made bigger in the context of COVID-19, and we can go maybe more specifically into what happened during the pandemic.
Thank you very much. Mr. Pittet, you want to tell us how COVID has highlighted many problems in our health system and patient safety especially. We were not ready.
We were absolutely not ready. Now, I like to be provocative like Rich Horton, the editor-in-chief of The Lancet, was in an editorial where he said, COVID-19 is not a pandemic. What it is. It's a syndemic. What is a syndemic? It's the conjunction of two diseases. One disease is this viral disease, this COVID-19. It's a new virus. Immunity was not ready. We had no immunity. But it's not a bad virus. It's not Ebola. Ebola is killing 80% of the time. COVID-19 is not such a bad virus, but it's a highly contagious virus that is coming to highlight the problems of our societies and of our world. And that's why you call it a syndemic and not a pandemic. It's a conjunction of two diseases. So what we have seen is that highlighted by COVID-19, in fact, we have seen inequalities in the world, inequalities in the healthcare systems, unpreparedness of the world to react to such a pandemic that was forecasted already by scientists for a while. So this is where I think that we need to understand that the bad disease was not COVID-19. The bad sickness was the way our world is unprepared to this type of challenges. And patient safety, I made my career in patient safety. I had the privilege to launch the World Alliance for Patient Safety together with Sir Liam Donaldson, the Chief Medical Officer of England. In 2004, Liam asked me to lead this Clean Care is Safer Care challenge that was actually to use alcohol-based hand rub in hospitals. So you were not aware about it, but soon it became popular because we used it during the H1N1 2009 pandemic, the H1N1. We used it during the SARS, COVID, and so on and so on. And nowadays we use it in the community, whereas we used to use it only in the hospital. Now, speaking of patient safety, when I say just, it's half of the problem of patient safety are healthcare-associated infections. The infections that you acquire when you come to the hospital, you are coming for something and you get something else, right? So those diseases, infectious diseases acquired in hospitals, kill every year in the world 16 million people. 16 million. It's more than AIDS, tuberculosis, and malaria that kills only, would I say, around 7 million, right? So it gives you the dimension of the problem. We know about it for years and years and years, but patient safety was not something that people were interested in. Now that we have solutions, we can reduce these infections in hospital by more than 50% just by rinsing our hands, and there are other things that we can do. So to come back to your demand is, yes, patient safety is a real issue. It's the #1 priority in the developing world, speaking of public health, #2 in our developed countries. But despite of this is what I call a silent pandemic. Nobody speaks about it. What if I tell you that in the United States, every day, there is the equivalent of a 747 airliner crashing with everybody dying on board? Did you hear about that? Did you hear that in hospitals in the US, every day there is the equivalent of a 747 crashing with everybody dying on board? If it would be the case, would you fly? No, you won't. So this is a silent pandemic that is to be and linked with patient safety that we have to deal with, and that's why we decided to have this summit on patient safety in Switzerland. Of course, the program has changed a little bit because it was organized for before COVID. I had the privilege to organize the scientific program for Alain Berset, and now we have modified it a little bit. We'll speak about healthcare-associated infection. We'll speak about antimicrobial resistance, another silent pandemic. We'll speak about all sorts of issues in patient safety, and of course, the link between COVID-19 and patient safety. So patient safety was compromised during COVID-19, not only because people got COVID-19 infections, came to the hospital, we had to treat them, but we had nosocomial transmission in the hospital of COVID-19. And we had also people who did not suffer from COVID-19, but were not treated because of their disease, because the entire health system was handling COVID-19. So that's the dimension that is absolutely huge of the patient safety issues linked somewhere to COVID-19, but also to the inequalities that I discussed earlier. So I will end up here.
Okay, thank you very much. I think that was a very good launch for the discussion we will have now. Maybe you touch on it as well. I just wanted to go to where we were before COVID, and I think at the international global level, the awareness had been raised on the issue of patient safety, but the implementation was lacking, and that I guess is when COVID happened and when we realized that we were not ready. Maybe you touched on it briefly at the end of your introduction, but can you maybe tell us the silent pandemic? Can you maybe give us the few categories of patients that were affected by this failure of patient safety?
Well, in fact, if you think about it, you have a hospital. Our hospital in Geneva is almost 3,000 beds, right? We do all sorts of things. We do everything. We do transplant, we do minor surgery, we do psychological support, we do everything. And suddenly, you have to work only on COVID, right? So, first of all, you get 80% of the healthcare workers out of the hospital because they have to be confined, right? And you work only with 20% of the staff, and you take care only of COVID-19. So what about you as a mother who need to be checked because you have a difficult pregnancy? What about you as a woman who needs to have your control for breast cancer prevention? You need these. What about you when you need to have your endoscopic exam because of this colon research prevention strategy that mandate you after the age of 55 to get a colonoscopy every 2 to 3 years. All of this was suppressed. So how many breast cancers did we miss? How many colon cancer did we miss? How many melanoma, skin cancer, did we miss? And I'm speaking only of cancer, but how many psychological support that we were supposed to do didn't we do? And so on, and so on, and so on. So the patient safety issues are huge. And today, we don't have the figure of what were the near miss. In French, we say perte de chance. It means that you have been missing something. And we don't know exactly if it will affect you or not. So just to give you a few examples. There are many more, of course. And among those many more, there is this patient with this hip that is arthrosic, and he needs a hip surgery, and he couldn't come to the hospital in April 2020. And today, because we are still late, maybe he's not operated. And for the past 2 years and a half, he has pain in his leg, right? And pain is increasing because arthrosis doesn't wait for us, right? So that's really something that we cannot measure completely, but this is really serious.
So we were at patient level, maybe let's go up to governance level, maybe to have a macro view. Did you identify flaws in the governance? Because that's your one of your themes, I guess, at the OECD. Do you also see different trends in different countries?
So, I mean, governance flows during COVID-19. There have been all sorts of things, not just on patient safety. I mean, quite clearly, we have seen even patients that came to hospital or healthcare setting without COVID, in many cases, caught COVID. And that's safety issues, in a way. It's like the ability of making sure that you have safe care for people that come without COVID, let alone those who could not have healthcare because beds or facilities were occupied by COVID patients. But I think that has been a significant issue as well. I think we have seen, a delay in reporting even information and data and indicators, and that's one of the things that we care quite a lot at the OECD about patient safety. So it's very, very difficult in the context of COVID, of a crisis, to have a clear picture and to have a real-time picture of what is happening. And that has highlighted pre-existing weaknesses in data infrastructure, for example. Before COVID-19, only about 2 OECD countries were able to generate real-time data and informations on issues related to quality, safety, and other indicators which are useful for management of healthcare. I mean, that's something which is unacceptable. And it created all sorts of issues for managing both COVID patients and non-COVID patients. Luckily, there's been progress. So there's been an acceleration, for example, in availability of real-time data, in trying to really making sure that we have more indicators linked across different data sets and so forth. But, speaking about governance, if you don't know when you're flying, if you don't know, how to fly, and your, control board instruments do not work, then you do have a problem. And I think in healthcare there are some unacceptable pre-existing weaknesses that we need to highlight. There is also the issues that we have mentioned a lot, hospitals. But what COVID also shown in terms of governance, and I alluded to at the beginning, the safety issues and the cost are not just in the hospital sector. I mean, the long-term care sector. COVID-19 is a disease that affected mainly, in terms of severe consequences, mainly people who were old or with multiple chronic conditions. In the long-term care sector, the safety, procedures, the protocols were not just in place. That was before the pandemic, and lots of people really had safety issues in the long-term care sector. So I think that's a fundamental one, even in terms of prioritizing personal protective equipment and basic infections control measures, let alone protocol and mechanism. The staff is not trained, for example, and we can talk about staff issues. There is the issues of staff being trained for safety. There is then also the issues of staff themselves being having, safety, COVID issues, but also mental health consequences, and, the whole patient's staff safety becomes also important. So, a lot of things that were coming to the fore with COVID-19, more on attention precisely to these different settings, to the data infrastructure, and to the need perhaps also to think, as we're thinking now about the future, there is a lot to talk about building more resilient health system, pandemic preparedness and response. And somehow we should avoid the risk of focusing just on, again, maybe on a narrow way of thinking pandemic preparedness and forgetting the fundamental issues that were there and were made more acute by COVID-19, like safety, governance.
So you were mentioning the staff, the health workers. So maybe a question for both of you, I don't know who wants to start, but what was the main issue? Was it that they were not trained enough, they were exhausted, and when you're exhausted, we all tend to make mistakes? Were there not enough of them because they were affected by the illness? What was for you the main problem there?
Well, I guess I can speak about it very easily, because it's a problem that existed before. We knew that in long-term care facilities, the number of people in charge of infection prevention, patient safety, is very, very low. Their training is extremely poor. Their salaries are extremely poor. The PPE, the protective equipment, even because it was missing in some countries, some ministries of health say, no, we keep it for the hospital. It was a big mistake. So we were not prepared. And we are not better prepared today. I can tell you, in long-term care facilities, it's still a very, very important problem. We didn't catch up. Then, of course, people had to concentrate on COVID and work hours and hours and hours. Some were very well prepared, but nobody was fully prepared, right? In some hospitals, people were more prepared than others. In some healthcare systems, they were better prepared than others. But nevertheless, at the end, we had to use people who were not used to do this type of exercise. And yes, they were extremely tired, and they still are. And today, we have this problem that at some point, everybody was going to the window to applaud the nurses and the doctors and so on. But it lasted a little bit of time. And in some countries, they got their salary increased a little bit, but not their conditions of work. And a lot of people quit the job. And today, in the context of a massive shortage of nurses that we know about for many years, because WHO is working on it for the past 10 years, there is a dumping of nurses in the world. In other words, nurses are trained like in the east part of Africa. They go to Middle East, they got their English better, then they move to UK, Canada, USA, where they are the place where we are missing the most nurses. Because nurses in the USA, it used to be a profession for that was very well recognized. Today it's not recognized anymore, so they are missing nurses. So we have this dumping of nurses worldwide, and on the top of it, we had this COVID-19 that overall made healthcare people sad about their work. They are tired about continuing to work like this, sometimes in bad conditions, sometimes in better conditions, but be poorly recognized, and so on and so on. So today, we do have a problem, in addition to what we used to have before, because things have changed. And people have been somewhere disappointed. Many of them have been disappointed. In Geneva, for example, in our hospital, which is, we were probably in the best conditions from around the world, right? But despite of this, we cannot go back to the level of activity we had before COVID. Now, we are missing personnel, we are missing sometimes even motivation and so on. So yes, it's a patient, in patient safety, we also have the protection of healthcare personnel. We need to make sure they don't get sick, they don't get the disease, they don't get infection. But I can tell you that today, we are not in a great position, speaking of the healthcare personnel. And I don't know any place in the world where it's the case.
No, yeah, I completely agree. I mean, it's the first issues, there were not enough healthcare workers, and we have a massive shortage right now. If we want to make sure that health systems are better ready to deal, say, even with the normal winter flu, there were issues. And then we had COVID. So we have now a generation of healthcare professionals which are completely burned out. The motivation is going down. Obviously you spoke about nurses, the care workers is a big issue. We're preparing a report called Beyond Applause in OECD, which really tries to put on the agenda how, okay, we clapped a lot for all these professionals, but after a few weeks of clapping, this stopped and they kept on working. So definitely, the working conditions is also an issue. So, lots of talk and discussions in a context in which also the healthcare professional is increasingly feminized, and so there are demands for different type of work arrangements. When you have shift work, that's very heavy on people who have a dual caring jobs and so forth. There are then issues, that were linked just when you have too much to do. Clearly, it's in a way easier to, I would not say make mistakes, but there can be things that happen. But I would point and completely address the issues of health workforce, including the fact that, we rely on healthcare workers, nurses and doctors from other countries, and this is a big issue.
Would you say that because this is quite a grim picture that you both depicted, but would you say that COVID highlighted that, and that now we know it, and do you think will it help finding solutions? Because I'm getting to my solution part, which is I hope will be a bit more optimistic. But do you think that now do you have an idea of the kind of solution? I mean, except throwing a lot more money into the healthcare.
Look, I'm optimistic by nature, so I would think that, lots of things are going on at national level, discussions at the global level about, how to make sure that we are better ready, better prepared, how to link the agenda of pandemic preparedness with universal health coverage, stronger health system, and so forth. So, that's the positive side. The negative side is that priorities have already quite quickly shifted to other issues, on a global scale. There is the war of aggression in Ukraine, there is a cost of living crisis, an energy crisis, and so forth. And in a way, I hear also from some of the countries, some of the policymakers, that they're struggling in negotiating budgets for health because health already got a lot, huge increase in health budgets during the acute phase of COVID-19. We're not out yet, but during the most acute phases, there was massive increases in resources going to the health sector. And somehow, we hear some countries, they're saying, well, now other parts of government's budgets needs to be receiving their part. So keeping this on the agenda for me would be a fundamental issue. And let's, also jump on the fact that health, is like everybody knows the importance of health. It's been so much clear that unless you have stronger safety measures, stronger health system, then we're all incredibly vulnerable. So let's jump on that and let's try to move all these measures and attention towards greater resilience of health system to make sure that we also address the patient safety. So a bit of more of a, optimistic, but it's not going to be easy because the context, geopolitical context has changed and the economic context.
Do you also think that maybe when we prepared this, you said something to me that I thought was very interesting. You were explaining that during COVID, the chain of command was changing. Yeah. So and that's decisions that were very slow to be taken and very financially oriented. That suddenly maybe the welfare of the patient was at the center. So is that something that you saw on a large scale? I don't know if we can broaden it. And do you think that this is something that we need to keep in mind, that we need to function to have a crisis mode where everything's changed?
Yeah. The crisis mode is sometimes helpful, and we have seen it. As I told you during COVID, but we have seen it during H1N1 in 2009. I've seen it during SARS when I visited the different countries with SARS problem. The chain of command need to change during a crisis. The example I always give is as a chief of service in Geneva, when someone in my team wants a pen, I had to sign, now it's on computer, I receive 8 or 10 messages and I need to click to say yes. So of course I don't do it, my secretary is doing it, but during, and this is boring and I'm losing my time with that. During the COVID crisis, it was not the same. I would ask for a pen, the pen would be here in 5 minutes in my hands, right? Now, because the entire system had changed. Now, it's the best way to handle a crisis. Whether we could do it on the long term is another issue. But, yes, we have been changing a few of our systems because of the crisis. And between us, European health did not exist before COVID, right? Now we are starting to see some sorts of things happening, which is good and necessary. Because as we say, the health system, the stronger the health system, the stronger the economy, the stronger the society. So there is no choice. We need to invest. Now the problem is that, yes, the investments are coming, but we are already, as you said, because of many other reasons, not really taking the lessons of the crisis. And that's the problem to me. We need to take the lessons of the crisis and to understand we were not prepared. Are we better prepared today? The answer is certainly no. Now, I had this privilege to look at the management of COVID asked by Emmanuel Macron for France, but in comparison to all over the world, and in particular to Europe. And I can tell you there are huge differences, and there were huge differences, and some countries have acted following the crisis differently than others, taking into action some of the recommendations that some experts told to the countries. So this is part of the solution. Do we want to be solution-oriented? This, when we started in 2004, today is saving 5 million lives every year in hospitals worldwide. It's a very simple solution. It's at no cost, right? Okay, not all solutions are so easy.
I'll go back to that in a minute.
Large, right? But there are solutions. I'm like you. I'm very optimistic. But we need to be optimistic provided people agree to be transparent with what happened. And to me, that's the most important problem, is the lack of transparency toward what we have done, what we should have done, and what we should do in the future.
I think that's also a very important issue for you, transparency.
Yeah, no, transparent, but absolutely. I mean, it's talking about data indicators and so forth. But there's this broader issues that patient safety, transparency in patient safety is not a given, because you need to create a culture of learning among the health professionals themselves, among the entire system, that if there is a safety lapses, is not going to be, put, as a penalty onto the staff. You know, it's the reason why also the aviation, which is often referred to as so, low instances of safety, is also because they have this learning culture. And I think that's a fundamental one. And historically, that is...
In aviation, if you learn on the simulator.
If you are a pilot, you should spend hours on a simulator.
Hours on the simulator.
Surgeons today, we start for 2 types of surgery to have simulators, but not for every type of surgeries to have hours of simulators before you operate on a patient.
Yeah, and also if there is something that happens, it's not by, a person might feel, oh my God, that was I responsible, what I did, and the tendency that we all have, I mean, we see children, as they have something, no, I didn't do anything, So I think that's opening, transparent learning and making sure that if there is an issue, that does not come to any penalization for the professional. That's fundamental one. I mean, as I mentioned, one of the things that we do is we collect patient safety indicators. We have been doing that for many years. Huge differences across countries in their willingness to report data and in their ability to collect those data from the healthcare system. And partly is because precisely, what is the culture that we have? Is it a learning culture? Is it an open and transparent? Or is it one which is more about, penalizing when there is a mishap? So I think that's fundamental. Another thing which I wanted to add, which is slightly different, but it's more the issues of trust in the health system, which in a way we see, and some of the data I was looking at about trust in the healthcare system following COVID-19 has gone down in a number of countries. And I think this is a fundamental. I mean, think about trust in vaccinations, and it's like If you look at some of the data about the people that still do not have had vaccination from COVID-19, most of them say that it's because they fear side effects and possible, safety issues, let alone about, trusting the safety with which the vaccine were developed. So I think these issues of trust, it's something that, in terms of governance of safety, we'll need to grapple with going.
Do you have example of best practices on that? What would be a good way to address it?
Well, it's best practices in a country. It's difficult to see, but it goes back to the issues again of transparency, of positive learning, linking efforts towards strengthening health system and resilient health system to patient safety. We go back, I think, to things that, in a way, were known before, but it's difficult to point to a country as a best practice. As usual, there are things which work well and things that didn't work as well.
At the same time, during the pandemic, there was this idea that there was a common enemy, so it helped really maybe transcend traditional managerial practices. There were maybe people work less in silos and stuff. Do you see lesson learned, and maybe that can also help building trust? I don't know, in a team, or did you see that? Do you think that's something that this different way of working in maybe small team and building up things, that's something we should keep, or is it just something we can do in crisis mode?
No, that's something that we are working on for many years. But are you prepared to use it during the crisis is the real question. And I mean, I'm sorry to say, but in April 2020, when we looked for plastic tubes for our laboratory to do COVID testing, they were in Hamburg in the port, and they were blocked by the German government, in case plastic tube will be missed by the German government to make tests. So, I mean, before working in a team and so on, we have many room for improvement. I'm sorry to say that during the COVID-19, we came back to a sovereignty action. So I'm outside of the patient safety issue here. I'm in health diplomacy. And I think that we failed. We failed. We need to say again that we failed. Then Europe was great when we decided to put money on the table for vaccines. Great, fantastic. We made some mistakes because we should probably have asked to companies for more return on investment, but that's another story. But this is patient safety also. Because if we would have been able to really offer not only the vaccines universally, but also the way to implement the vaccine, because it's not enough to get a vaccine. You need to have the way to implement it, right? And it needs money, it means publicity, it means communication, it means. So I think that we need to be very careful by saying that we did great. We didn't do great. We have to learn a lot, and we have to continue to. So yes, we have certainly learned to work in a team, but the crisis situation helped us. In our hospital, it was very clear. When I worked with the French government, it was very clear that it helped us to team up. Yes. Now, the work of team up, we tried to work on it for many years, since I was a junior, right? And sometimes it works, sometimes it doesn't work. It depends also of the people in the team and the capacity in the team to manage and to lead. So I would say that I'm not sure that we learned so much. We could have learned more. It's very clear. And let's hope we will continue to learn.
Did you also see that maybe at a more global level, the fact that there were more communications between different interlocutors, or maybe people working less in silos, also, I don't know, politically, or?
Well, I think you have both. I mean, you have seen more communications, more willingness to do together, but also a lot of silos and a lot of nationalism in a way, and that's something that we need to be better ready for the future. I mean, it's not that you address some fundamental weaknesses or failures during a crisis moment. When you're in the crisis, you're just trying to, do things and make sure that you fix the crisis. But it is right now that that you need to the lesson learned, whether it's in relation in terms of global solidarity, yes, vaccine, obviously development distributions and so forth. What are the rules for making sure that we make sure that those pandemic countermeasures are distributed in a more equitable way? Those are things that you work before the crisis comes. When the crisis comes, it's quite normal. And for elected governments, also it's quite normal that they need to think about my patients. I mean, that's what they're elected for. So it's if we want to have global mechanism of a different sorts and regional mechanisms, this is now the time. And we know that obviously, and Isabelle is here from the Commission, huge amount of things that the Commission has been doing that were unthinkable of before COVID-19. So there are lots of very promising, excellent developments, so which hopefully will make us better ready for the future. So yes, there's I mean, on the issues more at perhaps micro level, teamwork that happens, fine, but you also need to equip the health professionals and the teams themselves with the resources, with the personal protective equipment, with what is necessary for them then to work in a more collegial way. Otherwise, in times of crisis, again, you need to just run to address the urgent issues in front of you.
If you just, if I may add, on the topic of silo busting, I've been working with WHO since many, many years and leading a campaign since 1994. And I've been fighting, I have been silo busting for years and years. I'm privileged because I'm not working in WHO. Because if you work in a United Nations, silo busting is almost impossible. You have to be from outside to be able to silo bust. And that's another issue. The issue of silo busting is something that, yes, in the time of crisis, it's almost easy. But then immediately after the crisis, silos are rebuilt. So silo busting is really something that we need to work. So I fully agree. I mean, Europe was not constructed for health, right? The reason for constructing Europe was not health. So the future should think about, if health is heterogeneous in Europe, and it is, what should we do? And that's the real question. And we should first silo bust between the health system in Europe in order to make it. Because Europe is the defensor of democracy, definitively, in the world, if we do geopolitics, right? So that's why we really need to think about it and work. So the Commission has been working unbelievably good from, let's say, 2 or 3 months. I took three months to wake up, probably, after the March 2020. But then it worked. We have seen that European CDC was very, very, very weak. But look at the resources of European CDC as to compare to CDC US, right? I mean, I know about it because I almost take over CDC US, so I know about the resource there. So I think that we have to, it really has to be thought on a very large scale. And we are outside of patient safety, but in the middle of it is patient safety. That's your future, that's my future, that's the future of my children and our children in Europe. And again, I come back to transparency. We talked about it earlier. I can tell you, people doing my job in some part of Europe, and I'm not going outside because I know it outside too, when they count infections, we come back on transparencies. If their rates are too high, they lose their job. It took me 20 years to convince my CEO in Switzerland, in Geneva, to make the rates of infection in my own hospital transparent. So that's when you say countries have problems to have their data, in patient safety, it's a huge problem. Yeah. It's a huge problem. And in the so-called most developed nations, I say like this, you see my signs. in the United States, in fact, they have been to the opposite. So in patient safety, now when they have problem, they hide the problem. Why? Because insurance don't cover for healthcare-associated infections anymore. So we have to be very, very careful to find the right balance between transparency, science, and solution-oriented actions. So I think that this is the major issues in patient safety. And that's why in this meeting in Montreux, I invite all of you to make it on the 23-24 of February, because we really need to link the real issue of patient safety with the health systems and with the politics. Because we are heard now, but when I was speaking of a silent pandemic in 1992, nobody cares about what I was telling. Now people understand because they have been confronted to a pandemic, so they know what is a pandemic, right? But a silent pandemic is worse than a pandemic, and it kills more than a pandemic.
Maybe just to as you were saying, there's really a need for more data. And I think, did you see, I was thinking about all the innovations that we saw, vaccination, that well, everything was faster than normal. Did you also see some progress in data collecting or in any digital communication or?
Those are two different issues. Yeah. The digitalization broadly has accelerated through COVID-19. Obviously,
that's a good point.
That's absolutely a very good point. And countries have realized that they didn't have the data that they needed. So there's been an impetus, very, very strong impetus, to address issues that were related to the ability to link different data sets so that you could have a better picture of the whole pathway of care for a patient, issues to improve the timeliness of the data. All of that has really accelerated through COVID-19, and that's one of the good things. There's been definitely positive learning, digitalization, of course, in terms of telemedicine, all of these things, different roles for doctors, for nurses, for care assistants, for pharmacists that we didn't have before. So perhaps, speaking about silos, some of the silos have been broken in that respect about, thinking differently, more innovative, more creatively about our healthcare system. And I always say we have healthcare systems which are very rigid. They've been set up in decades, ago when the type of health needs of populations were different, and they're very much about the role of the hospitals, the role of primary care, and so forth. So we have set up a system which is not flexible enough and ready to face some of the upcoming challenges, whether it's chronic diseases, whether it's the possible occurrence of an unexpected shocks like COVID-19. So I think that the acceleration in some of the innovations that we have seen, and they have to do really with workforce arrangements, with data, with resource mobilizations as well, does create positive learning for the future. So it's, as I said, I'm a positive. The only thing is that, as I said, priorities are also shifting more at center of government level. So it's continuing also demonstrating the good things that happened, and where things needs to be learned. It's fundamental for the future.
Thank you. Maybe as a transition to the Q&A part of our discussion, I'll start with a question that will end our discussion between the three of us, and also start the Q&A session with this good question. Do you have three main messages for policymakers to foster patient safety in normal times to be ready in crisis time? So I don't know, more money, more, I don't know.
Well, maybe it's like this, but as I said, the cost of poor patient safety is, way above the cost of interventions that, can be put in place to address patient safety.
So more prevention.
It's just the economic case for patient safety is huge. There is not just a moral imperative and, and a health imperative. There is really also a cost issue. So that would be my first thing. And secondly, is that many of the things are actually quite easy, straightforward. The washing of hands, the infections, some of the infections control. These are things which are not so difficult or costly to implement. So it's a matter of, systems in place, in a matter maybe of will. And thirdly, I think it's like let's capitalize also on some of the learning from COVID-19 to address, to keep on maintaining patient safety on the agenda.
So maybe same question, but as Mrs. Colombo mentioned, the gesture barrière. I don't know how you say that in English. Barrier gesture.
Barrier gesture.
These days, I mean, we less and less people are wearing masks. People are crowding in the metro. Less and less people are washing their hands. So it was obvious for us during the crisis, but that has disappeared.
It's human nature.
Okay.
It's well known for many years.
How do we fight against human nature as a way to improve patient safety?
Behavioral change. Everything is behavioral change. So it means that when you were afraid for yourself, you use the hand rub, right? You use the mask. Now that you're not anymore, you're not afraid for the society, you stopped using it. So I've investigated that for the past 30 years in hospitals. So I'm modest with my conclusion on the community, but I guess it's not better because the advantage in the hospital is people are supposedly educated. But when you look at someone approaching a patient, he has a lot more capacity to clean hands after taking care of the patient, which is for himself, than before, which is for the patient. So it tells a lot about human nature. That's why we need to work on behavioral change, and that's not new. We speak about it for the past 30 years, but it continues to be so important. The advantage of a pandemic is you should never lose the chance of an epidemic, we say in our field, or of a pandemic.
Well, in the EU, we say never lose the chance of a good crisis. Yeah.
Yeah, but because it raises the awareness. I mean, I'm speaking about patient safety for the past 30 years, but nobody even knew what patient safety was meaning, right? Now we start to understand. And transparency is absolutely key. Without, if you don't know that you have a problem, you will never work on solutions to solve this problem. We have to allow people to know about problems, so transparency is a key. Then collective intelligence is a key. We need to work together, different people, multidisciplinary, and really collective intelligence. That is so important, but not only at a time of crisis. During the first wave, I had people coming to my home where I was in the hospital, giving to my wife protections that they made with a 3D scanner by themselves at home, telling, give it to Professor Pittet, I can do 30 a day to help protect healthcare workers. That's innovation, that's community, that's us living in society. So this is what we need to work on. We need to rediscover collective intelligence and give it the power to make significant change.
But how do you make campaigns? How do you promote those measures?
You make campaigns, you allow people to sit together, and at a very high level, what we have discovered during COVID, and you have seen it, because if you look at the data all over the world, just on mortality due to COVID-19, you see the importance of political decision. And we knew about it for years, but it's very, very clear this time, right? In other words, the politicians need to make the decision, but the scientists need to help them to make these right decisions. So I think this is absolutely key. In patient safety, this is exactly it. We have been telling healthcare workers that they are convinced that we have problem with patient safety, but we are telling CEOs for years that we had this problem. They didn't want, they just ignore it, most of them. Today, it's a different issue. We have made progress. So we need to take this opportunity to really build up our health systems in a way that we can, match aviation, nuclear. I had the privilege with the World Alliance for Patient Safety to visit British Airways safety systems, to visit nuclear power agencies, and so on, to see the resources that they are using, to see the tools that they are using. We don't use 1% of these in healthcare. We need to choose.
Is there a question in the room? Yes, please.
Thank you. Hi. I had a question about equality and patient safety. So we've seen sort of the COVID-19 data that the patient safety isn't equal between people of different races, genders, etc. So how do we raise patient safety as a whole whilst eradicating some of those inequalities?
Well, speaking, it depends what you mean about inequalities. If there are inequalities in healthcare, of course there are huge inequalities according to countries worldwide. But there are also huge inequality or large inequalities in my own countries, which is one of the richest countries in the world, right? Between some hospitals and some healthcare and long-term care facilities. So inequalities are everywhere, and they are inside of a hospital. There are cultures that are totally different. The culture of safety is absolutely key. You need to have a CEO that not only say patient safety is really our concern. It's not enough. The CEO needs to know what patient safety means. The CEO needs to visit the world and say, are you doing everything, or do you have everything to make sure patient safety is our first priority? So I think that you need to be very, sorry?
That's okay.
Yeah.
Let's
No, I
finish the
think
sentence.
that what you need to understand is that patient safety has been, it's a large basket, but if you want to find solutions in patient safety, you need system change, you need education, you need safety culture. And safety culture is extremely important. And this, today, is not there in most places.
So on the issues, obviously, huge inequalities which have been exacerbated by COVID-19. The first thing is that obviously, yes, those pre-existed, but whether they're related to socioeconomic inequalities or ethnic-related inequalities, those individuals who were from disadvantaged population groups were not only more exposed to COVID-19 because they had jobs which required them to go to work, because they live in cramped housing, because they have long commutes to do, So in a way, there are pre-existing socioeconomic situations that make certain population groups more vulnerable to COVID-19. And that has translated then into, higher infections and higher mortalities by a factor, but, for something like ethnic inequalities for the countries that collect those data, because not all countries collect data on ethnic differences, by more than twice the level of mortality across different ethnic groups. And the same for, looking at markers linked to income or to level of education and so forth. So the first thing is that you need to address those pre-existing issues, whether they're related to the workplace, whether they're related to inequalities in income and so forth. That's the starting point. There is probably an issue then which is more perhaps related to the healthcare specific, which has to do with more cultural specific also healthcare practices and activities. And that can have to do with even in some countries the language that's are spoken in a healthcare setting, to the engagement a level of community workers or leaders about the information which is given, because patients and people from different socioeconomics or ethnic groups may be more attentive and more responsive to communication that comes through certain people or through certain means. So it's this whole cultural sensitivities also that needs to be thought through.
I have a question from online. Do you agree with the idea that we are always prepared with excessive beds, staff, equipment, just in case of future pandemic? People may disagree because the measure would lead to costly healthcare. So you didn't speak a lot of money. I was quite surprised. You didn't say we need more money for. So it's a way. So
I mean, first thing, it's. What was the most binding constraints in the pandemic? It was not the bed or even the ventilator, it was the workers. So that's, the first thing that you need to invest, because it takes so long to train
also in patient safety, do you need more money in patient safety as well?
No, you need more people first.
More people and, money.
More and better trained people.
But, so yes, I mean, some countries, and we started to collect after COVID really data on ICU beds, for example. We have always had data on inpatient beds. But inpatient beds, in a context of crisis, if it's not equipped with ventilators and other things, then it doesn't really help. If you don't have the workers for it and it's not equipped, it doesn't help. So the ICU beds, huge variations even across EU countries in the availability. And so, of course, if you have a critical low level of ICU beds or those equipments, then you are more vulnerable. If you look at my country, Italy, compared to France or to Germany, level of ICU beds were incredibly low. And at the early phase of the pandemic, in Lombardy or some of the Nordic regions, which were supposed to be the best in the country, they did suffer just because of the lack.
But just to say, ICU bed, we knew about it for 20 years.
Yeah, but we don't even knew, it's like we didn't have data on ICU beds. I mean, it's like...
They were published 10 years before COVID.
Not a comparable level.
Yes.
Well,
I was part of the group at the ICU in Europe who look at this.
Yeah.
So we knew already these differences. Now it's a little more subtle because you have the number of beds and you have the number of people working in those beds.
Yeah, that's
the number of active beds. But
I think the question was more on being ready. Did we have too many? Do we have to have many beds ready in case of a pandemic? But that costs a lot of money.
But
while we're not in a
thing.
pandemic.
I mean, as I said, workers is the things that takes more time to have this surge capacity. I mean, it's a matter of surge capacity.
So we need to invest a lot in the training of workers.
Yes. I mean, equipping, obviously you need to start with some minimum levels, because if you don't have enough and you have all your resources already occupied, then it's very difficult to have surge capacity in a moment of crisis. And that has to do with the COVID-19, but also, the winter flu, which I mentioned. There are some countries that are struggling through the winter
Switzerland.
So, some degree, and there is a lot of discussion right now as part of this resilience discussion about the scare capacity. To what extent a resilient health system may need to compromise on some of the pure efficiency, if you want. So how can we make sure that we have both resilience and efficiency? So, you need, of course, to make sure that resources are utilized properly, but you also need to have mechanism for raising surge capacity in a moment of crisis. So maybe also ability to re-equip hospitals, ability to make sure that you mobilize care workers that might be in a sort of reserve, as we have seen in some countries and so forth. So all of these are part of the discussions which are going on, But
now, to provide a very simple answer to this question, when you lead a hospital, you should never have a hospital that work at more than 90% capacity of your bed capacity. Ideally, a hospital should be full at 70 to 75% so that you can compensate for the period like flu that is coming now and eventually help compensating for extra needs. You will never be prepared. In our hospital, we have one of the largest ICU that you can imagine. We have 35 bed ICU. Very large. I'm not counting the specific ICUs, but the large ICU. We were able to equip our hospital with 180 ICU beds. But of course, for these, we needed to use all the operating theaters and all the staff. The problem was not to equip. The problem was to have the staff available, trained. And as you say, these people should be multitask, because we cannot have an ICU that is working with 65 beds all the time and then suddenly double the amount of bed and have the same amount and quality of healthcare worker at the bedside, right? So we need to find systems where people are more polyvalent, but medicine today is not going for polyvalence, it's going for specificity. So that's one of the difficulty to cope with this emergency. But hospitals make the mistake to run, and my hospital is among them, we are running at 98% bed capacity. So when the flu season is coming, you are in the corridor, right? So we need to invest more in health systems, but in particular to invest more, as you said, in the healthcare staff, because it takes years to build up a staff that is able to be polyvalent.
Maybe another question from the room? No? Yes, please.
Well, thank you so much also to the Swiss mission for organizing this really interesting exchange over breakfast. I would like to build on what Professor Pittet has said in the beginning about the fact that health didn't exist so much at European level. Because a direct consequence of the pandemic is that we now have the European Health Union, yes, which I think is first raised by President Macron when he spoke about une Europe de la santé. Mm-hmm. And indeed, the Commission is doing a lot, ranging from pandemic preparedness to more data, health data, as well as a pharmaceutical strategy. But do you feel, and perhaps I'm asking both the professor as well as Francesca, also with the health at a glance data in mind that has been presented this week, are we doing enough on patient safety to raise awareness or in terms of policy actions?
We are clearly not. It's very clear. We are clearly not. It's good. It's a good move. But we have been asking for it for years. Years. Without nobody listening to us. Even 20 years ago when we discussed, even more, that we discussed the creation of European CDC, we asked immediately for a lot more, not only resources, but resources is important, but you need willingness. You need decision makers to say, this is important.
And do you think the European level is, the question is what can we do at
we
the
can
European
do much
level?
Better. We can do much better, but we need to agree that a European health should be built. And that's the issue. And yes, President Macron was very active. President Macron was the one who asked the other chief of states to put the money on the table for the vaccines. Okay? So I'm not sure all were agree at the beginning. I know that some did not agree for probably economical reasons. So that's why we need to change our way of thinking about it. Health should be universal. As soon as there is one weak country in Europe speaking of health, the other country will or can suffer of it. So I'm talking about health because that's what I know, but I had the privilege to look at economic, society, and public policies during this mission I made. And I can tell you that I see the same thing in education, I see the same thing in many fields. So I think that to answer to your question, yes, we are moving in the right direction, but we need political decision to make a universal health coverage, at least in Europe. And this is not the case at all.
Do you think that there's a role for the European Union? Since we're in Brussels, I guess the question is also...
No, absolutely. I mean, of course, the European Union is already doing so much. But I mean, a few issues, obviously, like healthcare professionals, which has been mentioned. I mean, patient safety is a lot about having healthcare professionals, about having them trained, about having that culture. And I think probably, at EU level, more on healthcare workers. And there are some actions joint actions which are going on, but that's definitely a key priority to further strengthen. On the indicators work, we have for many years worked with the European Commissions who have really helped and supported also the efforts that we do to work with countries so that we can collect better data, we can have more transparency as it was mentioned. And and I think again in this context of thinking about how to be better ready to a crisis and the emphasis on resilience, safety and resilience are part of the same, it's two sides of the same coin. So I think there is an opportunity, in there in building on all the different initiatives which are going on. So yes, more can be done. It's not that nothing has been done up to now. And I would definitely say that probably this transparency and safety as well at the workforce could be some starting points. Yeah.
You think more? What role can the European level play in comparison, for instance, to national levels? Would you say it's just to have a common culture, or to?
Well, common culture. I think it's a big word. I mean, if you mean if transparency culture is something that you work on at each level, there is a lot in terms of learning of practicing, best practices. For example, the Commission is doing quite a lot of work on best practices and implementing also and scaling up useful practices in one country into other settings. That's something, for example, that we are working on. I mentioned the indicators and the measurements efforts, but we have here also the Commission. So maybe I don't know whether they want to also add to this question.
Yes, please. You sure?
Okay. So in health professionals, we have been working for a lot of time.
Hold on.
Wait for them.
We have been working on health professionals for a long time, and not only the joint action, as has been mentioned, but also the training of some specialties. During the COVID, we trained 17,000 health professionals on ICU skills. So not specialists, but people that could be deployed in the unit and working with the European Society of Intensive Care Medicine. So that was very, very interesting, and I think that very, very important. The pandemic also offered us the possibility of increase the money of the EU for health. That was, I mean, this is serving to build all that you are mentioning. But also, for example, everybody talks about the next generation funds and the possibility of using for the resilience of the health system. But in reality, countries are not using much on the health system. They are using in other things, but this is something that has happened with many other funds. I don't know, in the time with the asylum, migration and integration funds, when the ministries of health are going there to request for some money, all the money has already gone to other ministries or to other needs, and we are afraid that this is happening now with the resilience fund. So I think that we need to insist, because the COVID is like in one side we had fatigue, and now has been forgotten. We are in other different things, monkeypox, Ukraine, whatever, and this is the threat that we forget. We hope also that the new regulation is going to help. You were comparing the ECDC and the CDC, for sure that we cannot compare, because it's not the same thing in origin. We are not, United States is a federal country. We are not a federal country. We are not. So we didn't establish the ECDC with that idea in mind. And just to say that we began to work in February 2020. So at the very, very beginning. And maybe one of the difficulties was that, well, you know that the article of the treaty that is about health is very weak, but once that we invoke the 122 of support, that when we had the emergency support instrument and we could go. So I think that we didn't did so bad, but we did. I mean, everybody, what we could. What we knew is easy now to evaluate what was done 2 years ago when we didn't know anything about that. So we cannot evaluate the past with the knowledge of the present. But I think that was not so bad. And I just wanted to mention the confidence in vaccines, because Francesca already mentioned that we just published 2 weeks ago the confidence report on vaccination, focused mainly measles, HPV, seasonal flu, a little bit on COVID, and we are worse than in 2018. So we went like that, and now we are. And yeah, of course, because one of the themes that we closed were the vaccination services. So what message are you transmitting if you close the vaccination services for children? But it's more important that the gap between the more aged people and the young is widening. So the youngster believe less in vaccination, and this is a real problem that we will need to.
That's a good example of patient safety, because I mean, we have seen it all over the world to close these vaccination centers or to raise the doubt about vaccines, because of course, I mean, for anti-vax, that was their time of glory. You know, if you go surfing, if there is no wave, you will not surf, right? When a wave is coming, you go with your surf and you can surf. And that's the problematic of the infodemia that we had during this pandemic, which was very, very complicated. Yesterday night when I took the taxi to go to the hotel, the taxi driver asked me what was my job. I said, I'm a doctor. I said, oh, I'm against vaccines. And we started, and he was like explaining to me that the company were doing this. He knew about it. In March 2020, he knew about the vaccines. And I mean, so it's terrible to see that. It's terrible to imagine that we couldn't really cope. And we knew it would come, but with these tremendous bad publicities about vaccines, that, by the way, save lives. I mean, we know about it. And
maybe you want to react, but I know there's a last question, maybe. Did you want to say something? Thank you. That would be the last question.
Mirka Cikilova from the European Patient Safety Foundation. I think the Europe and the Commission and European Union will certainly come to give general directions to where the European health should go, which direction. But the national governments and the countries will still have the most important role. And we know that some countries, they do better than the others, northern countries than the South and Central European countries. And so my question is, do we know which countries have their national patient safety strategies and plans developed, and which are only working on it, or which countries even don't know what it is? So do we have an overview about this? And is this maybe going to be addressed during the summit?
Mrs. Colombo?
So, I mean, you can look at some of the reports that we have done, but I would add a more general point that, do you know which countries do better or not? And the problem goes back that some of the countries that are more open about these issues, that have, a safety plan, that are reporting data to us, which are taking care to make sure that those data are, solid, robust, and so forth. Those are the countries that are doing quite a lot. And maybe in international comparisons, they may look as if they're worse than others that do not report. So I think there is all of this just to say that there is still a huge amount of work to be done, even in terms of benchmarking what countries are doing, because precisely is this issue of the transparency. That's the idea of being open about safety issues, about when there are problems, when there are things that needs to be improved. It's a cultural things, and so I would not just take as a given even some of the data that even us as the OECD report to say this country is doing better than others. I think this country is reporting better than others. That's certainly something that we can say. But maybe as a point, all of the countries that we work with have made huge progress, and at international level, the fact that we have this summit, it's the 5th patient safety summit. I mean, it's what is fantastic is that it's countries themselves. It's not an international organization that say, let's do a patient safety summit. It's the countries themselves that, in subsequent ways, they have decided to host a global patient safety summit to make sure that this is on the agenda internationally, but also domestically. And I think that's really fundamental, this, country-led leadership. It's really very important.
I will invite you to come to the summit.
So let's finish on this positive note. Thank you to all of you and thanks to both of you first for this very interesting conversations. Thanks to you who were in the room and to you who were following us online. Maybe a last word for you who are online. There's a survey at the end that you can answer, and it would help us very much if you could take a few seconds to do that. So thank you very much in advance, and I wish you a very good day, and wash your hands and keep your distances.